Here is the new episode of our YouTube series on practical OBGYN problems, where expert faculties share their views on any interesting topics. Since these videos are posted to YouTube, one can watch it as and when time permits them. Our today's topic is postpartum hemorrhage, practically speaking. It is presented by Dr. Anand BHAGDE. Dr. Anand BHAGDE is a young Foxian and emerging as an expert faculty. He was first in MS examinations and proud recipient of gold medal. He is fellow in minimal SS surgery from Eva Hospital, Ahmedabad, fellow in hysteroscopy from Ashwini Endoscopic Center, Pune. At present, he is a treasurer at Jamnagar Obstetrics and Gynec Society. He is presently working as a private consultant in OBGYN and laparoscopic surgeon at BHAGDE Maternity and Nursing Home, Jamnagar.
Hello everyone, dear friends, colleagues and respected seniors. At the outset, I would like to thank Dr. SUDHIRSHAH for giving me an opportunity to express my views on prevention and management of postpartum hemorrhage in his series of How Do Experts Manage It? PPH is commonly defined as blood loss exceeding 500 ml following a vaginal birth and 1000 ml following a cesarean section. It could be primary or secondary, that is, after 24 hours and up to 12 weeks after birth. Definitions of PPH vary, however, and diagnosis of PPH is subjective and often based on inaccurate estimates of blood loss. To make things easy, usually it is managed clinically as follows. Minor PPH, which means up to 500 to 1000 ml of blood loss and absence of any clinical signs of shock. Major, it includes an estimated blood loss of more than 1000 ml which continues to bleed or signs of shock present with smaller EBL. It could be either moderate or severe, that is more than 2000 ml of blood loss. In this presentation, we will mostly be concentrating only on the clinical and practical aspects of managing PPH rather than going into the theoretical aspects. Prevention of PPH is much better than managing it therapeutically. There are very basic questions which we as obstetricians deal with in our mind on a daily basis. The first is active versus expectant management. It has been proved without doubt that although the active management has been associated with increased incidence of nausea, vomiting and raised BP, it is much better than expectant management. Now in the active management, either it is prophylactic oxytocin versus no uterotonic. It has been proved that prophylactic oxytocin reduces the risk of PPH by about 60% and the need for therapeutic oxytocics by about 50%. The third question is prophylactic combination of ergometrin oxytocin versus oxytocin alone. Now, ergometrin has a 5-fold increased risk of unpleasant side effects like nausea, vomiting and elevation of BP. Thus, we have to balance the advantage of a reduction in the risk of PPH of between 500 and 1000 ml against the adverse effects which are associated with the use of drug. In cases of PPH less than 500 ml, there is a small reduction in the risk of PPH with oxytocin alone rather than a combination drug. So for women without risk factors for PPH, oxytocin alone could be a good agent of choice. While considering prostaglandins and other carboprost, it has been found that injectable uterotonics are much preferable and better acting rather than using these drugs as a first line drug. Now there is a new drug, carbetocin, 100 microgram of single dose is as effective as oxytocin by infusion. However, it has not been recommended to routinely use it because of the paucity of data and its high price. Now, since we talked about prevention, we should also be aware that who are at risk for PPH. Certain conditions which are present antenatally and they substantially increase the risk for PPH. Suspected or proven placental abruption, placenta previa, multiple gestation, and gestational hypertension or preeclampsia. Other conditions present antenatally and they significantly increase the risk for PPH, like previous PPH, Asian ethnicity, obesity with a BMI of more than 35, and anemia with a hemoglobin of less than 9 gram%. Now, other conditions which become apparent during labor and delivery: emergency or elective CS, induction of labor, retained placenta, mediolateral episiotomy, prolonged labor with a duration of more than 12 hours, big baby with more than 4 kg birth weight, pyrexia in labor, and maternal age more than 40 years. However, we need to keep even in our mind that PPH happens in patients where you least expect it to. Now, before we proceed for the management, we should attempt a quick assessment on the cause of hemorrhage. We all know the 4 T's of postpartum hemorrhage. Is it the tone? Yes, which is present in 90% of the cases. Is it the trauma, the tissue, or the thrombin? Now, at the beginning of my presentation, I mentioned that clinical management will be categorized into 2, minor and major PPH. Hence, we will move ahead like that. Now, the first and the foremost part of a management of PPH involves communication. In cases of minor PPH, communicate with the midwife, first line obstetric and anesthetic staff. However, when you are suspecting a major PPH, in addition to the above, we should also be communicating to the porters of delivery of blood, laboratory personnel, and one team member in our hospital staff to record events, fluids, which includes input and output charting, drugs, and vitals. Also, one should always bear in mind that a minor PPH can turn into a major PPH at any time of the event. Now, for resuscitation, the first important part is airway and breathing assessment. Then we proceed towards evaluation of circulation. 2 14-gauge IV lines are taken and 20 ml of blood is taken for diagnostic tests. In minor PPH, we should immediately commence with crystalloid infusion. And in cases of major PPH, in addition, we also require the transfusion of blood or blood products ASAP. Now, when we talk about fluid replacement, total volume of 3.5 liters of clear fluid is the maximum to be infused while awaiting compatible blood. The nature of fluid infused is of less importance than rapid administration and warming of the infusion. When it comes to blood transfusion, if fully cross-matched blood is unavailable by the time that 3.5 liters of clear fluid have been infused, Group O RHD negative blood is the safest way to avoid a mismatched transfusion. Also, when the blood loss reaches up to more than 4.5 liters, which is 80% of the blood volume of our body, and large volumes of replacement fluids have already been given, there will be clotting factor defects. Up to 1 liter of FFP and 10 units of cryoprecipitate, that is 2 packs, may be given empirically in the face of relentless bleeding, which while awaiting the results of coagulation studies. Antifibrinolytic drugs like tranexamic acid may also have a place in the management of major obstetric hemorrhage. There is a role of recombinant factor 8A. However, it should be used after consulting with an hematologist and also considering in mind that the availability is limited owing to its financial cost. Talking about monitoring and investigations. In cases of minor PPH, just blood group and screening, full blood count, and a coagulation screen is necessary. However, in cases of major PPH, in addition to the above, a cross match with minimum 4 units, baseline renal function and liver function tests are required. We should be monitoring vitals every 15 minutes, insert a urinary catheter, manage an input-output chart, and central venous line is taken if necessary, if the cardiovascular status is compromised. The central line can also aid in rapid fluid replacement if necessary. At the back of our mind, we should be thinking about transferring the patient to a high dependency unit once the bleeding is controlled. After the supplementary measures are over, our main measure is to arrest the bleeding. And as I said, that 90% of the causes of the BPH are related to uterine atony. The sequential management of it is as follows. The first and foremost, mechanical and pharmacological both. So it begins with bimanual uterine compression. Then oxytocin 5 units by slow IV. Ergometrin 0.2 milligram by slow IV or IM, maximum up to 5 doses. We should bear in mind that it is contraindicated in cases of hypertension. After that, oxytocin infusion is started, 40 units in 500 ml of Hartmann's solution at 125 ml per hour. Then carboprost 250 microgram can be given, which could be repeated at not less than 15 minutes interval to a maximum of 8 doses. There is also a great advantage of a direct intramyometrial carboprost, which is easier in cases if it's an LSCS. It is also possible to inject intramyometrial carboprost through the abdominal wall in absence of laparotomy. And then finally, misoprostol 1000 microgram per rectal insertion. If the above measures fail to control the hemorrhage, intrauterine balloon tamponade is a good method of choice. Balloon tamponade has been proven to avoid hysterectomy in up to 78% of women. Various types of hydrostatic balloon catheters can be used, like Foley's catheter, Buckley balloon, Sangsteken Blackmore esophageal catheter, or a condom catheter. Tamponade test, a positive test indicated by a control of PPH, means a laparotomy is not required. There is no clear evidence on the duration. However, 4 to 6 hours is usually adequate. If the tamponade has failed as well, surgical hemostasis can be taken up. It has been proven to avoid hysterectomy in up to 81% of women. Now, various versions like the B-Lynch, Heyman, Wu and Kafali are available. None have been proven to be superior than the other. So it is really important to familiarize with one technique and be good and effective at it. If still there is relentless bleeding, internal iliac artery ligation or selective uterine artery embolization can be achieved. However, they are not as effective as the balloon tamponade and the hemostatic suturing. Also, they are a difficult technique considering the surgical skill as well as the logistics involved. Probably the requirement of an interventional radiologist in cases of embolization is the most difficult to achieve in every setup. However, they can be considered in cases of placenta previa with accreta. Also, it should be borne in mind that they do not impair future reproductive outcomes. Hysterectomy can be taken up as a last resort by an experienced clinician. It is important to do not delay it until the woman is in extremis. Subtotal is usually the choice unless there is trauma to the lower segment or cervix. Post-operative phase of these operations are equally critical. Hence, continuous physiological monitoring and psychological counseling of the patient, if necessary, should be there. Also, thromboprophylaxis should be considered if not contraindicated in cases of thrombocytopenia. In such cases, use of pneumatic compression devices is usually sufficient. Proper follow-up and necessary investigations for coagulopathies and screening for rare complications like secondary panhypopituitarism, that is the Sheehan's syndrome, should also be done. Now that we have considered the treatment of uterine atony, let's discuss a bit about the remaining 10% of the causes of PPH, that is the trauma, tissue and thrombin. In those cases, like laceration, hematoma, uterine inversion or rupture of a segment, retained tissue or an invasive placenta, or coagulopathy difficulties which would be diagnosed on blood investigations, in those cases only the treatment of the cause usually suffices. Supplementary measures like fluid volume management and blood or blood component management should be done as and when required. At the end, a very small mention to secondary PPH. The most common cause of secondary PPH and the cause which is invariably present in those cases is infection. Hence, investigations like high and low vaginal swabs, blood culture if there is pyrexia, full blood count and CRP is indicated. A pelvic ultrasound is also necessary. And as I said, as it is usually associated with endometritis, treatment involves over and above the uterotonics, antibiotics and surgical measures to evacuate the uterine cavity if necessary. A very small mention for rare indications of use of interventional radiology in cases of PPH. Emergency cases like uterine atony, as already described, surgical complications during LSCS, and bleeding following hysterectomy. In elective cases, like a known or a suspected case of placenta accreta, such as placenta previa on a previous CS scar, or a diagnosed placenta accreta by a scan or a color Doppler or an MRI. In those cases, there is a role of interventional radiology. Finally, my most important take-home message, that is risk management. Training in the form of annual skill drills, follow-up meeting which analyzes the case in detail and to document that what can be done in future to help manage the case in a better way. Accurate documentation of each and every detail of the case and debriefing to the patient, her family, and especially our birth attendants who are already emotionally and physically toiled. Thank you. Thank you everyone.
Thank you very much Dr. Anand BHAGDE for a very interesting and educative talk with slide presentations of our day-to-day practice. Friends, please like the link and share it to your friends, colleagues and students.